All right. I'd like to introduce our next speaker, Dr. Bruce Korf. Dr. Korf is the Wayne H. and Sarah Cruz Finley Chair in Medical Genetics, a professor and chair of the Department of Genetics, and director of the Heflin Center for Genomic Science at the University of Alabama at Birmingham. Dr. Korf is also a past president of ACMG and is the president of the ACMG Foundation. Dr. Korf?
Thank you, Mike. It's a great pleasure to have an opportunity to participate in this webinar. What I'll be doing for these next few minutes is reviewing a number of case studies on the application of genetic testing to both newborn screening and preconceptional screening for cystic fibrosis. These are my disclosures, none of which are relevant to this presentation. The first case is that of a newborn baby girl who is found to have an elevated IRT, and DNA testing is done as part of the protocol, and that reveals that she has two mutations, is a compound heterozygote for the G551D mutation and the common deletion of phenylalanine from codon 508. From a clinical point of view, she's currently doing well. She has no evident symptoms, but a sweat test is done based on the newborn screening results, and this confirms a diagnosis of cystic fibrosis. Her parents are educated about the condition, and she begins to obtain care, including surveillance and treatment in a cystic fibrosis clinic. The diagnosis of cystic fibrosis using consensus criteria includes having one or more characteristic clinical features, and then additionally either the presence of two pathogenic mutations, and the G551D and the F508 deletion would each constitute a known pathogenic mutation. Lacking that, there could be two consecutive abnormal sweat chloride values defined as more than 60 milliequivalents per liter. And this protocol describes at least one abnormal sweat test. It doesn't specify whether two were done or not. Or a transepithelial nasal potential difference that is characteristic of cystic fibrosis, which was not done in this case. The combination of mutations in this child, though, predicts that, in fact, she'll have cystic fibrosis, and more specifically, the form that is associated with pancreatic insufficiency. So what management would be appropriate in the setting of a newborn who is diagnosed based on newborn screening, not on the presentation of clinical signs or symptoms? Given the certainty that she will develop classic cystic fibrosis with pancreatic insufficiency, one begins with a set of therapeutic interventions anticipating the essential certainty of her developing a variety of both respiratory and digestive complications. So this includes airway clearance therapies that are well established to try to maintain open airways as long as possible. The institution of pancreatic enzyme supplementation, realizing that she has a form of mutations that would predict pancreatic insufficiency. The administration of fat-soluble vitamins, realizing that this would be a difficulty otherwise in terms of absorption, providing appropriate nutritional supplements, and also oral sodium chloride supplementation. A program of surveillance would be instituted to monitor growth, of course, to be looking for symptoms, especially respiratory and digestive symptoms, including things like stool output. Monitoring for respiratory infection particularly, realizing that there is a risk of colonization with bacteria that can become resistant to commonly used antibiotics. There'd be a variety of laboratory values that would be monitored, including vitamin levels, liver function tests, CBC and PT. And then also evaluating for what could be described as silent disease. This is a child who, as of this point in time, is not manifesting disease. This will include imaging, pulmonary function monitoring, and potentially bronchoscopy. There is no specific standard established yet for monitoring a currently asymptomatic child based on newborn screening. but these are some of the kinds of monitoring strategies that might be used in this setting. Now, the particular mutation, or one of the two particular mutations that this child has, the G551D, potentially lends itself to treatment with ivacaftor, which is a recently FDA-approved drug that is used in the setting of individuals with a particular mutation, namely the G551D. This illustration shows the processing of the cystic fibrosis transmembrane conductance regulator protein from the Golgi to the surface of the cell membrane, or to the cell membrane, where it integrates as a chloride channel. Particular mutations either result in the instability of the protein and its targeting for the proteasome where it's degraded, or in just abnormal function as a membrane channel. There are now studies underway to identify drugs that can potentially correct either of these problems. So-called potentiators would interact with a mutated protein in the cell membrane and enhance its ability to transport chloride. And so-called correctors would salvage the otherwise mutated or abnormal protein so that it would potentially not be degraded in the proteasome. Turns out that G551D is really the first example of success in this area. This is a screenshot showing data from a New England Journal of Medicine paper from 2011, looking at individuals with the G551D mutation, where the potentiator ivacaftor was used. Compared to placebo, you see a very substantial improvement in forced expiratory volume in individuals who were treated with this medication. Now, ivacaftor would not be a drug typically used in a newborn like this. The drug is currently approved down to 6 years of age, and clinical trials are underway down to 2 years of age. So this would not be a child who, based on age at least, would immediately be treated, but this certainly would be a drug to have on the list to consider as the child gets older. Our second case is another newborn screening case. This is a newborn boy found to have a high IRT, and his DNA testing provides a somewhat different result, the G551D mutation, but here in compound heterozygosity with an R117H mutation. He has a normal sweat test, and he's also doing well clinically. So his parents are educated about the findings, and he's introduced to the CF clinic, but based on this genotype and also his negative sweat chloride testing, he's not started on specific medications or nutritional therapy. So this particular combination of mutations predicts the likelihood of mild CF with pancreatic sufficiency. One can use fetal elastase as a way of establishing pancreatic function. Fetal elastase is an enzyme secreted in the pancreas that is excreted in the stool, essentially unmodified, and therefore is a good measure of pancreatic function. So if there is pancreatic insufficiency, one sees a reduction or complete absence of fetal elastase. It otherwise is expected to be present in the setting of pancreatic sufficiency. Now, the R117H mutation has a special sort of relationship with a polymorphism called poly-T, which I'll describe in just a moment, and would be relevant in terms of predicting what the degree of phenotype might be in an individual who carries that mutation. But this is an individual who could be at risk for CFTR-related disorders such as recurrent pancreatitis or congenital bilateral absence of the vas deferens, being a male. This is an illustration of the poly-T mutation and its relationship with the R117H mutation. So poly-T actually is a polymorphism of having either 5, 7, or 9 thymines in a site in the intron just after exon 8. And if there is a 5T allele, which is the shortest run of CFTs, there's a tendency to skip exon 9 in the context of splicing. So you get a in-frame protein that includes exons 8 and 10, but not exon 9, whereas the 7 or 9 T alleles are associated with normal splicing. Now, as to what happens phenotypically, there's all sorts of different possibilities. In the setting of an R117H mutation on one chromosome and a known CF mutation on the other, which is the setting here, if there's a 7T allele, one might see congenital bilateral absence of the vas deferens as a phenotype, whereas if it's a 5T allele that is in cis with the R117H, mild cystic fibrosis is the predicted phenotype. Now, you can actually have a phenotype even in the absence of a second CF mutation. R117H in trans with 5T can also give CBAVD, and homozygosity for 5T itself can also be associated with CBAVD. So one actually would need to know the poly-T genotype for this child to make a better prediction of what phenotype might be expected. The third case, also a newborn screening case of a girl who's found to have a high IRT. And this time the DNA testing shows only a single pathogenic mutation, which is G542X, a known pathogenic mutation. It would be a stop mutation. She has poly-T sequencing and is found to have a 7T allele associated with normal splicing. And her CFTR gene itself is sequenced, and no additional known pathogenic mutations are found, although this does not rule out all possible mutations, such as copy number changes. She has sweat chloride testing and fecal elastase, and these are both normal. And so she's also started on surveillance in a CF clinic, and her parents are educated about the condition. This is a child who might be described as having CFTR-related metabolic syndrome, which is defined in terms of having a single CFTR mutation or a borderline sweat test, not abnormal enough to be diagnostic of CF, but nor normal. And the protocol here would involve every 6-month monitoring in a CF clinic, focusing on growth and GI function, as well as respiratory function and microbiology, that is to say, specific bacterial flora in the sputum, and then to initiate therapies as needed, but not otherwise. So far, the evidence would suggest that only a minority of individuals in this category actually develop signs that would be diagnostic of cystic fibrosis, though the possibility of other CF-related syndromes that were mentioned earlier would still need to be considered as a possibility. Well, our next cases are going to turn attention now from the newborn screening to preconceptional screening. So the first one is of a couple who are screened prior to conception, and the woman is found to be a carrier for the F508 deletion mutation, and her partner is screened and eventually has his gene sequenced and is found to carry just R75Q, which is an amino acid substitution, which is not believed to be pathogenic. In spite of this, the couple are anxious about the risk to a fetus, and an amniocentesis is done. The fetus, in fact, has the 508 deletion, which means that the fetus at least is a carrier and actually has a very low probability of having a second mutation based on the father's sequencing. And in fact, deletion duplication analysis is done on the father and no mutation is found. This is a table which was derived from the Gene Review's website, looking at the frequency of detection of CFTR mutations in different settings. And so we're considering 3 different approaches to mutation testing: targeted testing using the 25 mutation panel, and then the sensitivity in 4 different ethnicities in the United States, a deletion or duplication copy number variation analysis, and sequencing of the CFTR gene. So in individuals of Ashkenazi Jewish ancestry where a founder effect is known to occur, the 25 mutation panel is 97% likely to find a mutation if there is one there. Non-Hispanic whites in North America, the sensitivity is about 88%. African Americans, 57%. There isn't good data on the Asian American frequency. One can add deletion or duplication analysis, and estimated between 1 and 3% might have these copy number changes that would not be seen by targeted analysis. And then gene sequencing should pick up essentially all of the mutations except deletions and duplications. And so it has about a 98 or so % sensitivity, and with the balance of mutations being deletions and duplications. One would expect that essentially all of the mutations that would have potentially been pathogenic would be picked up by a combination of deletion analysis and gene sequencing. So the result in this family, given all of that, remains reassuring. Well, finally, a couple are being treated for infertility, and CF screening is done as part of this. The mother is found to have a single base deletion, which would be a frame shift and pathogenic, but the father is not found to have a CFTR mutation. So in preparation for in vitro fertilization, his CFTR gene is sequenced. And what it reveals are a set of variants of unknown clinical significance. And then the fetus was conceived, found to have inherited the mother's mutation, and 3 variants from the father, but not necessarily variants that are known to be associated with cystic fibrosis. And I think this illustrates the challenge of sequencing, which is sometimes, as in the previous case, it can give substantial reassurance, or conversely, of course, it might actually identify a known pathogenic mutation that is rare and is not otherwise on the targeted panel. But sometimes you will find variants of unknown clinical significance that haven't been proved to be pathogenic, but nor have they been proved to be non-pathogenic. And in such settings, there may remain uncertainty as to the outcome in the fetus. So I think I've said most of this. One can look at these variants of unknown significance either by searching databases of known CFTR mutations, but when one looks at the genomic level, one tends to find variants that could be unique to a particular individual, or at the very least sufficiently rare that they haven't been seen before. One can try to analyze them in terms of whether they are altering a conserved amino acid, which, if the amino acid is highly conserved, might tilt you towards believing that it's pathogenic, but that doesn't necessarily prove that it is. Or doing computer analysis to assess the predicted impact of that mutation on protein function. But that too is a uncertain kind of analysis, in the sense that things predicted by computer analysis to be significant in terms of protein function do not always turn out to have significant effects clinically. So one needs to be prepared for the possibility, when one looks at the genomic level, of finding variants that are not going to be easily resolved in terms of what they mean for the later clinical outcome of a particular individual. Well, in summary then, a lot of progress has been made, both in terms of newborn screening and in terms of preconceptional screening. The newborn screening offers the possibility of an early diagnosis of cystic fibrosis, with the expectation that prompt institution of treatment will ameliorate some of the signs, certainly save the child from what may be, at least in the early time in life, recurrent infections and failure to thrive, which are the ways that cystic fibrosis historically has presented, and instead permit education of the family and prompt institution of treatment, which may avoid complications, prolong well-being and health for a much greater period of time, and also serve as a basis for future genetic counseling of the family. We need to recognize that some diagnoses of the cystic fibrosis related metabolic syndrome may occur, and the long-term outcome is going to be more uncertain in those cases, but still surveillance can be instituted and treatment instituted in turn if deemed to be clinically indicated. Preconceptional screening has been going on for more than 10 years. It offers the possibility of providing timely counseling to couples, not waiting for the birth of their first affected child to make them realize that they're at risk. And the 25 mutation panel has brought us a long way in terms of providing a basis for this counseling. The dilemma, however, occurs if one partner is found to be a carrier and the other not, realizing, depending on ethnicity, there still may be substantial probability or possibility of carrying a mutation. And the addition of both sequencing and deletion and duplication analysis can significantly increase the sensitivity in those kinds of situations and offer potentially reassuring information. But one needs to be prepared also for the possibility of finding variants of unknown significance, which can complicate the analysis. Finally, I'll say the example of ivacaftor is one of what I expect will be a series of new discoveries and developments in terms of treatment, offering more and more the possibility of gene-directed therapeutics that we hope will improve long-term outcomes. So a lot of progress has been made in the areas of both newborn and preconceptional screening, and genomic approaches are adding significantly to the power of that approach and the ability to inform families as precisely as possible to give them information to guide the decision-making that needs to take place and the management of a child who's been identified by newborn screening. So I hope this has been helpful to place some of the various points that have been made by other speakers in this webinar into context, and I very much appreciate the opportunity to participate. Thank you.
All right, thank you, Dr. Korf. Appreciate your listening to this webinar, and we'll welcome you back for one of the other series from this group of webinars. Thank you very much.